Thank you. Thank you very much. Thanks to Andy and Kath particularly for inviting me. We did work together in the last century. Try not to sort of think about that was too long ago. Would really encourage you to support what John's research, really interesting stuff. My encouragement would be, don't forget about the mental health of older people. Having just come from earlier in this week, the first World Health Organization ministerial meeting of 80 countries across the world, looking at how to defeat dementia. And all of the rhetoric is about getting the right drug, preventing dementia. Both great. I want a drug for dementia, I want to prevent it. But I also know that there are 47 million people worldwide living with dementia right now. There's going to be many, many more into the future, and we'll touch on some numbers in a minute. And having practitioners, nurses, doctors, psychologists, OTs, social workers, that can really deliver the skilled care and support that people need. The need for that has never been greater. And yet we're still having people come off nursing courses, medical courses, psychology courses, who feel very under-skilled in working with people with dementia and their families. So please don't forget.
If anyone's got a particular interest in older adults, of course come forward, you're really welcome, and your experiences going into that area will provide a great diversity in the stories that we thanks for saying that, Dawn.
Okay, so in this talk, what I'm hoping to cover is just a little bit about the Association for Dementia Studies, because certainly if you're interested in this area, that's a great local research centre, only down in Worcester. I can remember when I worked in Birmingham, I thought that Worcester was on the other side of the planet. It's not, it's only 40 minutes down the road. So in terms of having that as a local research partnership, please, I'll give you a bit of info about us. I want to continue to talk a little bit then about why dementia is important, and then hoping to cover 4 core skills that everybody working with dementia needs. Okay, so this is our team. Association for Dementia Studies, founded at University of Worcester in 2009. Our remit is about developing an evidence-based practical ways that help people live well with dementia. So this is my team here. There's now around 30 of us. Many of us have background in the NHS or social care. We're a multidisciplinary group. Many of us are nurses, some of us are psychologists, OTs, physios, few medics, few social workers. And at any one time, we've got about 30 projects on the go. About half of those are research, so looking at the sort of patient pathway right from pre-diagnosis, how we get people diagnosed, and then through care and support as the dementia progresses right through to end-of-life care. So a lot of interesting research going on. The other thing that we spend a lot of time doing is working with people who are already in practice to help bring them up to speed on what they need to know about dementia. We have a current workforce that knows that feels very underconfident, where there is a serious lack of knowledge. So that's us. Visit our website if you're interested. That'd be great. The other bit that I want to say about ADS, the Association for Dementia Studies, is that we take the experience of people living with dementia and their families very seriously. And we have an experts by experience who we call our link group, which is what they decided to call themselves. And these are people with a diagnosis of dementia and family supporters. They inform the work that we do at all stages, they teach on our courses, and they contribute to our research portfolio. because it's only by really listening to the voice of experts by experience that we can keep what we do very real. And the people here, we work very closely with our local memory assessment service, and there are lots of people who are newly diagnosed, who maybe were lecturers, teachers, were used to teaching, and by utilising their skills, it gives them a really big payoff in terms of staying engaged and active as well. As I said, what we're interested in is developing evidence-based, practical ways that help people live well with dementia. You know, we're in a bit of a famine and feast in terms of the information that's available on dementia. There's never been more available. When I first qualified, there were 3 books on dementia, and most of them were Australian. You know, there's a huge amount out there at the moment. The problem is, most of it is either very superficial or very dense and difficult to apply in practice. So one of the things that we try to specialise in is to have good, easy read, but sophisticated materials that you can then use to inform practice. And the ones that I put up here are ones that we've developed over the last few years. One that purple book, the Nursing and Health Survival Guide, we developed after we'd run a number of 10-day leadership programmes in dementia, particularly for hospital staff. So these senior nurses who are meant to be, you know, organising what you guys do on placement, who often really feel underconfident around dementia, and how you turn round the sort of attitudes that there is in a lot of hospitals around why, you know, seeing why dementia is important. So the purple book was basically our knowledge base that we were imparted. Looks huge there. There it is. It says the small print, you know, and it's bullet points. So we had to cut the rubbish. We had to cut the the flowery stuff that I usually get a lot out of writing. But, you know, it's the knowledge base, and there's stuff in here about how you assess pain, how you work with somebody that doesn't want to take their tablets, how you diagnose dementia, what a Wernicke's encephalopathy is, you know, what a frontotemporal dementia is, how you work with people at end of life, what help families need. That's all in there. That's the small stuff. The big stuff is attitudes. You know, as I'm sure many of you will have experienced on placement, you know, or you've heard, I'm sure, some of the good things that Andy and Kath would have told you. And then you come up with an attitude like, well, that patient shouldn't really be here because they've got dementia. We're too busy saving lives to sort this person out. You know, has anyone heard those sorts of attitudes on placement? Yeah. So, you know, and don't get me wrong, we have some fantastic examples of good practice in hospitals and some fantastic care homes, but that's not the norm still. And I guess we're looking to you to change that. One of the big reasons we need you to change that is the numbers of people living with dementia. So these are figures from the Alzheimer's Society. In 2012, around 800,000 people in the UK were affected by dementia, set to rise to 1 million by 2021, set to rise to 1.7 million by 2051. So if you think you're going into the health service not to work with old people, you know, that will become an increasing part, and already is an increasing part. And part of the problem is that although we've known about this huge rise in numbers for many years, we haven't acted upon it, and we haven't produced a healthcare system that can cater for large numbers of older people. So back in the last century, when me, Andy and Kath were you know, cutting our teeth on mental health services for older people, there were probably only about 150,000 people in the country with dementia. It was a rarity. We'd call a psychiatrist if a person with dementia appeared in a care home or a hospital ward. You know, it was unusual, and we had a whole specialism around it. Now, this isn't specialist. This is core business. But what we haven't moved into is having a health and social care system that treats it like core business. It's still a sort of specialism. It's still something that, you know, those people working in organic mental health need to be dealing with. This is everyone's business. People don't go into hospital because they've got a dementia. They usually go into hospital because they've had a fall, or they've had a stroke, or they've got cancer, but they've also increasingly got dementia as well. And it's that complexity of multi-morbidity that is the challenge that we face. Okay, so that's the numbers game. We also recognise, so if you look at the figures in for Worcestershire and you look at your age range, we can see that, you know, if you didn't know, people also get dementia at younger age rates as well. You know, people in their 30s, 40s and 50s get dementia. They're a relatively small percentage, but if you get a diagnosis of dementia or you get some of the symptoms of dementia whilst you're still at work and whilst you still have school-aged children, that makes that diagnosis often much more difficult to deal with. So what we need to be very clear about is that dementia just doesn't happen to older people, but age is a significant risk factor, and it happens to more older people. You know, so if you look at that bottom line there, which is our 85s, you know, in a county of nearly 600,000 people, we've got about 3,700 if you look at the sort of estimated rates. That's set to double by 2026. And when you're looking at dementia in that age group, you're usually looking at 5 to 6 comorbidities as well. So it's not just the dementia. And that's the complex challenge of skilled care. Okay, I'm not going to do a big bit about what dementia is, because second year you'll know this already. I might get one of you to stand up and tell me about it. But just to put some basic key facts to help us understand the rest. It occurs, dementia is an umbrella term for a set of disorders that occur as a result of progressive damage to the brain caused by an underlying disease process. Okay. Common causes: Alzheimer's disease, vascular dementia, dementia with Lewy bodies and frontotemporal dementias. Those are the ones that you'll most commonly hear of. There are about 150 different types of dementia. The vast majority of them are very rare, and if you're nursing someone with the rare one, you need to mug up and find out about it. But the most usual ones that you'll come across are those four. Dementias usually affect many parts of the brain's cortex, which is the thinking bit, over time. So there's usually a progression. Many people live for 10, 20 years with dementia. Some dementias are very slow and insidious, others are faster. And as a syndrome, it includes memory problems, reasoning, communication problems, and a gradual decline to be able to understand everyday activities. Okay, so I'm not going to spend a lot of time talking about what dementia is, but firmly get the idea that this is a set of different types of disease processes which affect people's brains in very different ways. We all have different brains to start off with, and the impact is different depending on your age and health. Currently, we're failing to meet the needs of people living with dementia and their carers. This was a slide that was shown by the OECD at the World Health Organization conference that I've just come from. And this is a review that the OECD have done of dementia in post-industrial countries, so in the rich countries in the world. And whatever metric you take, it's not good news. More than half of all people with dementia are undiagnosed. Try and think of another serious health condition where we would tolerate only half the people getting a diagnosis. Recent study in the UK showed that only 1 in 3 of people with dementia leave the house once a week. So if you look at loneliness and isolation, it's huge. Carers of families of people with dementia are 20% more likely to have mental health problems themselves. A third of those in care homes are being prescribed antipsychotic medication, so the sorts of medication that John was mentioning earlier that's used to control symptoms in people with psychosis. Nobody with a dementia should be on an antipsychotic as a first-line treatment, and they should be reviewed every 12 weeks. And many people in care homes are on antipsychotics that were prescribed 5 years ago. Hospital costs 3 times higher than for other people with the same condition. If you've got a dementia as well, you're going to spend much longer in hospital than if you haven't got a dementia. And a third of people come out of hospital with reduced functional ability. So I think the case is compelling for improving our quality of care and looking at our skilled care. But no country has got this right. You know, in many respects in the UK, we're doing better than most. And yet still we're struggling to get the skills that we do know about into practice. And one of the other things that we've started as part of the World Health Organization Action on Dementia is a group called Global Action on Personhood. And there's me doing my bit for radical thinking at the World Health Organization. By delivering skilled care, we can really support the person to live well with dementia. Nobody wants a diagnosis of dementia. We all want a cure. But recognising that that is not on the cards at the moment, there's a lot that we can do to help people and their families cope well with dementia and live their lives in spite of it. By delivering skilled care, we can prevent those excess disabilities, distress and harm that are caused by poor quality care. We can end that inappropriate use of antipsychotics just to control behaviour. We can end the physical restraint that goes on in many countries where they don't prescribe antipsychotics. Yeah. In many of the African countries that were speaking at the World Health Organization, you know, the challenge they face still is that if you have the symptoms of dementia, you'll end up in a witch camp, you know? So it's the level at which we're working because we don't put skilled care into practice is enormous for the world. Okay. Excess disability and harm. The majority of so-called behaviour problems that we see in dementia are the result of untreated physical health problems, untreated pain, poor nutrition and hydration, boredom, unmet emotional needs, the care provider's lack of understanding of cognitive capacity of the symptoms of dementia, poor communication, poor knowledge of the person's history, and poor general care. So if we're looking at skills, those are the things that we need to be addressing if we're really going to be providing that skilled care. So I've just chosen 4, which are ones that I think are the ones that are often missed out, but would make a big difference if we could put it into practice, and if we could get every nurse understanding these 4 things. The first thing is really understanding cognitive capacity in dementia and what some of the symptoms are that people experience because of the underlying dementia, how that impacts on the brain. And we know from that little slide that I showed earlier and from your studies that different types of dementia will impact on your brain's cortex in different ways. They will have different progressions and different presentations. But over time, what we see with most dementias is that every area of the brain is implicated, every area of thinking is implicated. And we know from our neurology that different parts of the brain are associated with different functions. So by understanding that, it doesn't make the dementia go away, but it means that our response can be one that is helpful and rehabilitative. So some of the major cognitive symptoms that you will see. Memory, particularly difficulty in remembering recent things. So things that have been in there a long time are well remembered. The challenge in dementia is putting down the new memories, particularly common in Alzheimer's type dementia, and I'm going to talk a bit more about that in a minute. Communication, gradual decline in being able to follow conversation and to express yourself through language. So over time, being very good at communicating and understanding some of the common problems in communication in dementia is particularly important. Typical sort of Alzheimer's type communication pattern early on will be lots of difficulty remembering nouns. So, you know, it's the what's it on the thingy. You know that, oh, what's it called? It was her who, what's her name again? You know, so it's the missing out of the names. And if you're sitting there and you know what the name is or what the thingy is, helping somebody along with that will help the conversation flow, rather than leaving somebody struggling to do that tip of the tongue experience. Language, we know as well, if you've got somebody for whom English is second language, even if they were very fluent in it, second languages deteriorate more quickly than mother tongue. So important there, if you're working cross-culturally, cross-language, that people need to have the experience of speaking to somebody in their own language, but also recognising that they will get dysphasic problems in their mother tongue as well. You know, so you're working with a straight interpreter, they need to understand a bit about communication in dementia. Body awareness, difficulty doing practical tasks, putting a pair of pants on and then putting another pair of pants on, or putting your jumper, your legs in your armholes of your jumper. You know, all of those sort of muddling up how my body fits together and how it fits together with the world. Very common in dementia and very misunderstood. Visual processing, having a lot of difficulty interpreting your visual world. So we often hear about people having problems during the twilight, you know, when the lighting goes down. And we've all had that experience where we've seen maybe a dressing gown on the bed and thought it was the dog lying on the bed or whatever. Those sort of misinterpretations are very common in dementia. And so making sure that the lighting's good, making sure that the visual world is unambiguous can go a long way to be really helping people live well with dementia. Executive function, disinhibition, particularly very distressing early on in frontotemporal dementias, but also becomes more distressing in other types of dementia as well. That lessening of our social control. You know, your frontal cortex is the last bit to develop when you're children. You know, it's the last bit that develops of the brain, and it's something that we're very used to seeing poor frontal lobe control in very young children. So I think the best example I ever had of that was my colleague Hazel May, who described taking her son Johnny to the swimming baths, and when he was 2.5. Now, if you go to the swimming baths with your mum, where do you get changed when you're 2.5? In the female changing room. So they're there getting changed in the communal changing room. Rather large lady comes out of the swimming pool in a big wet costume, turns round, starts pulling her costume down over her nice rounded bottom. Johnny runs across the changing room and slaps her on the bum. No frontal lobe control. You know, big bottom, great stuff. When he's 5, he'll have stopped doing that. He'll be like, oh, Mum, oh, God, fat lady over there, you know. But it's exactly that same sort of, we wouldn't sort of blame Johnny for that. We might be embarrassed by it, but we wouldn't, you know, think, well, that's because of, you know, he's being a particularly awful, terrible person who needs locking away. And yet, very similar, if you've got lack of frontal control and you've got somebody leaning over you with a low top on, you reach out, you know. And what happens then? What happens to the person with dementia is the one that gets labelled as being sexually inappropriate, or, you know, that we can't cope with that sort of behaviour here. So understanding those sort of disinhibited type behaviours, although it doesn't take the behaviour away, it helps you cope with it much better as a professional, and means that you can support people around to understand what might be going on. So skill 1, understanding cognitive capacity. And recognising that over time, people's cognitive capacity changes. And if we're looking, therefore, for ways of keeping people active and not bored, we need to make sure that we are matching the type of activity that we would be suggesting that we might engage people with, or the way in which we engage people, with their level of cognitive capacity. And again, once you're going down to late stage, doing a quiz with somebody is not going to work. Do you see what I mean? So it's about being very good at, if you're designing an activity program or a way of keeping people interested, understanding where somebody is on that sort of cognitive capacity scale. Okay, skill 2. Understanding the interplay of past and presence and the importance of emotional well-being. Alzheimer's timeline. I said I would talk about this a bit more because it's a very common cognitive problem, and it's a very useful way of trying to interact with people. So by and large, in Alzheimer's dementia, which account for about 60% of the people you'll see with dementia, what was in first is the last out. So stuff that was there in early childhood and teenage years and 20s is usually really well preserved. The stuff that people will really struggle with, is information that is going in since the dementia, but also probably the 20 years before the dementia set in. So that's really important to know about for a number of different reasons. Emotional reactions in dementia are as strong as ever. So although cognitively you might be losing that ability to remember facts, your ability to feel joy, happiness, excitement, shame, embarrassment, fear remain as strong as ever. So what dementia doesn't impact on is your emotional reactivity. And often what we do, or what the process that people seem to go through, is that if we have a feeling, our mind is usually drawn to the last time that we felt that feeling. Yeah. So if you are embarrassed, you remember the last time you were embarrassed, you know, and you start reliving that sort of loop in your head. If you remember, if you're very frightened, the memories that it triggers off is the last time that you can remember feeling very frightened. So do you see where I'm going with this? If we've got people in hospital or in care homes who are embarrassed or frightened, often the memories that will be playing over and over in their heads are other memories of traumatic times. On the other hand, if we can get somebody into a state of happiness and joy, the memories that start getting played out in their head are other happy, joyful times. So it's that interaction that past events and memories feel much present than recent ones, and that present events will trigger past memories. So one of the issues around skilled care is trying to create an environment where people feel relaxed and happy, because that in turn will generate other memories and other feelings of relaxed and happiness. We know that people with dementia have a high risk of not being treated as full citizens, of being ignored, disparaged or abused. People often have particular disabilities around communication, strong emotional responses, and this major need for continuity and to feel connected to others. And if we are providing skilled care, we need to deal with that in a proactive fashion rather than leave it to chance. So, for example, the observant of you will notice that I have a nice picture of fish here. This is my care home list. So if we turn this nice picture around, and you're a member of staff that's on in the morning, you've therefore got some pretty basic information about Dawn Brooker. You know, you'll know that I have to have my glasses on straight away that I wake up. It'll tell you that I like strong coffee in the morning and weak tea in the afternoon. You know, those sort of personal bits of information to get people through the day. And there's lots of these sort of easy products around, because if you're working with somebody with more advanced dementia, they won't be able to tell you that stuff. So it's about having it ready, at the bedside, easily accessible and known by all. And then there's the sort of more personal stuff. You know, knowing who I am, what I love, what scares me as a person. There's a basic information, and then there's the more important stuff. This picture is of a man that developed dementia in his 70s, and he's probably one of the most famous people in the world that we've had who developed dementia. Anybody old enough to know who he is? Well done, Ronald Reagan. For those of you who've never heard of Ronald Reagan, he was President of the United States, and he was also in the movies as well. So, you know, we used to joke when Ronald Reagan got dementia, if he was in our care home, we'd have lots of life story stuff that we could work with him and make his experience with us good. But in Ronald Reagan's mind, the time that he went back to was neither being the president or being in films. He went back to when he was a lifeguard working in Illinois. So a lot of his memories, the songs he liked, the food he liked, the stories that he told were around that time during his 20s. And that's often the case with people who we're working with. You know, some people's life stories we know lots about, many we don't. But the internet is a marvellous thing. If you know the year that somebody was 16, and you know the country in which they were 16, and you Google or you put on, you know, one of those many websites, give me the top 10 tunes in this country in this year, it's there. If you play those top 10 tunes, what will it do? It'll start to engender those positive memories. Because although it might not be the favourite piece of music, it will be reflecting a time for a lot of people, not all, but for a lot of people, when they felt powerful and potent and good and looking forward. It will remind people of their first kiss or their first dance, you know. So it's about, there are very easy ways that we can use this fact that we've got some really well preserved memories to try and make people's lives better and happier and decrease the need to give somebody antipsychotics because they're cross. Skill 3, be a physical health vigilante. We know, you know, and I think this is the really interesting bit about working with people with dementia in some respects. It's not about good psychiatric care, it's not about good physical care. People with dementia need both. If you have, you know, we know what is good for the heart is good for the brain. If you want to keep people functioning at a good emotional level, ensuring that people get exercise, fresh air, get to use their bodies, will really help with blood supply and keep them feeling good about themselves. We also know that that pain is very under-recognised in dementia. We have a number of research studies now that show, certainly for people who call out a lot or shout, a prescription of paracetamol will often decrease calling out and shouting. You know, simple pain relief goes a lot to, would be a lot better for people than the antipsychotic medication. People with dementia will often not say that they are in pain, but there are lots of pain scales and ways now of assessing the pain status of people with dementia, and that's about skilled care, is knowing how to assess pain in dementia. People with dementia are often very poor at reporting physical symptoms. So not saying, oh, when I go to the loo, you know, it really burns or hurts. Not being able to say, oh, I fell out of bed and my shoulder went all funny in the middle of the night. People won't remember those things. So it's incumbent on us to be really vigilant about those, about thinking about physical health. And any noticeable sudden increase in confusion, rule of thumb, it's probably something physical that's going on top of the dementia, and it needs investigating. Skill 4, being a top-class communicator. Listening, attending with your eyes, your ears, your brain, and your heart. So really paying close attention to what people are saying, both verbally and non-verbally, what words people are using, what the emotional tenor is. By doing that attending, you can often work out what it is that somebody is trying to tell you or to communicate. We talked a little bit about some of the important factors in communication. Providing structure, not letting people drift into long confusion, trying to bring people back into a conversation. You know, it's a bit like a game of tennis. You've got to get the ball over the net and back again. So it's maintaining that structure that will enable people to feel confident to return the ball back to you, as it were. Second language we've talked a little bit about already. Courtesy, respect, friendliness and kindness. Turn it up to the max, because often people with dementia, particularly more advanced dementia, may not hear it or may not feel it unless you're really communicating it well. Okay. People will remember how you made them feel more often than what you said. There's a nice quote here from an Australian writer called diagnosed with dementia at the age of 46. And she's written some lovely books, most of which are called Dancing with Dementia in some way, shape or form. And this was her advice to nurses. How you relate to us has a big impact on the course of the disease. You can restore our personhood and give us a sense of being needed and valued. There is a Zulu saying that's very true. A person is a person through others. Give us reassurance, hugs, support, and meaning in life. Okay, I just want to finish with a series of some pictures of skilled dementia care. This is a lady called Mrs. Mae Williams, who was admitted to the Lady Forrester nursing home. She had been cared for 7 weeks in the local general hospital. She got dementia, she'd had a chest infection, she got pneumonia, but she was still alive after 7 weeks. She was referred with this great care plan at the top: all needs, no mobility, not eating. So essentially she'd been sent to Lady Forrester to finish her days and not to die in hospital. This is a picture of Mae 6 days after admission to the care home. So she's sitting up, she looks a bit poorly and dishevelled, but she's dressed and she's taking some notice of what is being shown to her there. 1 month, she is baking. This is a lady who has always been a homemaker. She likes cooking and sewing. She might not be able to cook a full Sunday dinner anymore, but she certainly knows what happens, what she does with a gooey flapjack mix when it's put in her hands. Health and safety is being observed here. She has her blue gloves on, but is clearly enjoying that memory of making food, being sitting in the kitchen and having a chat. So baking. 6 weeks later, we have an Italian meal at this particular care home. She's certainly looking a bit fuller in the face there, and had her hair done. And certainly the not eating seems to have gone out of the window. She's certainly looking like she's looking forward to her Italian meal. 6 weeks later, tea and teddy, possibly spanning lots of good memories of cuddling other soft animals and little people, and looking very relaxed in her armchair. 2 months later, having an Indian head massage. I doubt whether Mae has ever had an Indian head massage before in her life, but you can see by her face that actually this is a new experience that she is very much enjoying, so it's not saying that it's all about past, it's also about living in the presence and feel confident to experience new things too. Knitting. Old skills returning again. She can no longer knit a whole fair old jumper, but she certainly knows what to do, which, the feel of wool and knitting needles in her hands is something that is very familiar to her. Silk scarf making. 3 months later, we've got her up dancing to music. And there we are, having a Mexican celebration. I think these might have been during the last World Cup, some of these themed evenings that they were doing within the care home. But, if we compare that lady after 3 months, no all needs, no mobility, not eating. Skilled care. It's about staff skilled in the understanding of cognitive capacity, being able to link paths to present, being health vigilantes, getting her fed, nutrition, pain relief, all of those things that can make her fit and healthy, and communication. And the outcomes for this lady is she's alive. Weight gain, happy, active, still got dementia, having fun, no behavioural symptoms and no sedation. So take home messages from this. Skilled care transforms lives. If we put these skills into practice globally, we would save millions of people from misery. And we don't have to wait. 2025 is the year by which globally the challenge is that we should expect a drug cure for dementia. We don't have to wait that long. We can do this now. And we're looking to you guys to do it. Okay, thank you very much.